So the question is, in a patient who is ALK positive, who is on crizotinib and has isolated disease progression in the brain, something that we've sometimes called oligoprogression, should that be a signal to the oncologist and the patient to consider changing therapy, or are there other strategies to help manage that patient? What we know of almost virtually all drugs that we use in oncology that are given systemically, whether by mouth or intravenously, is that the penetration into the central nervous system or brain tissue can be variable at best and is usually far lower than what we see in other tissues in the body. This has unfortunately become more and more of a problem for our patients, because what it creates is a sanctuary site for the tumor cells, because the drug just doesn't have access to that compartment of the body as well as other tissues. So it's not necessarily a true representation of failure of the drug. The cancer cells haven't figured out a way to beat the drug or become resistant to the drug. They're just not seeing adequate doses of the drug. So I think there are multiple strategies that are emerging. So some of the newer ALK inhibitors have shown efficacy in the CNS. I think although we've seen evidence of responses in the brain with the newer generation ALK inhibitors, we don't yet know how long those are lasting. So again, it's likely that the penetration of those drugs is still not optimal, but maybe better than crizotinib. Crizotinib has now shown data that there is some CNS penetration or brain penetration, that they can see responses. But again, the worry is that those responses are shorter lived and that it's easier for the tumor cells to grow in the lower doses of drugs. So one strategy is to think about switching to a newer generation inhibitor. But if you've got great systemic control, meaning that the tumors in the lung or liver or bones are very well controlled, and you've only got a few isolated lesions or perhaps only one isolated lesion in the brain, it would make sense to consider using radiotherapy to treat that. And so we and others have shown that by radiating these sites of disease progression, you can actually extend time on drugs. So again, thinking about the longevity of the patient and trying to minimize toxicity. We know that focal radiation, sometimes called stereotactic radiosurgery or SRS, of course, there are multiple names for the radiation machines that are used to do this. But by using that focal radiation, it's very non-toxic to the patient. There are very few side effects. And that often allows us to continue the crizotinib much longer than switching. And in fact, the progression in the brain seems to be a better strategy, because again, it's not necessarily heralding that the tumor cells have figured out how to get around the drug. What we saw in a study where we looked at patients who had only a few sites of progression, either in the brain or outside of the brain, was that the patients that we treated with radiation for disease progression only in the brain seemed to have a much longer time on drug following that radiation than if we radiated a site, for example, in the lung or liver. And probably that's because radiating those sites in the lung and liver might eradicate those spots, but those were heralding signs that the tumor was starting to evolve drug resistance. And so I think especially for the brain, radiotherapy is a reasonable option to consider. If you have more lesions, you might have to then weigh whether whole brain radiation is necessary. That does come typically with more side effects like fatigue, and so that's something that we have to consider in the equation, but might be necessary, again, even for some of the next generation inhibitors where there might be better activity, but perhaps not ideal activity.